Good morning and welcome to our Sickle Cell Data Collection Program for California webinar series. I'm Faith Rader from Tracking California's Sickle Cell Data Collection Program. I will be today's moderator. Mary Brown and Jennifer Fields, both working with the Sickle Cell Disease Foundation. So Mary Brown has been the president and the CEO of the foundation for nearly 20 years. It's a nonprofit organization founded in 1957. It provides education as well as life-enhancing programs and services to individuals with sickle cell disease. Ms. Brown has served a variety of healthcare-related nonprofits. Currently, she is the board chair for the Community Health Charities of California and also a board member of the Sickle Cell Disease Association of America and Painted Turtle Camp, a summer camp for children with life-threatening illnesses. She also lends her leadership skills serving as the director of Camp Crescent Moon, which I believe is for children with sickle cell disease. And in 2012, Ms. Brown was recognized for her work by the American Camp Association when she received their Legacy Award for the Southern California and Hawaii section. Ms. Brown is a graduate of California State University, Los Angeles, where she earned her BA in Education and Psychology. And she will be joined by Jennifer Fields. Jennifer is the founder and president of the Hills Tandem company. She has over 16 years of experience working primarily with nonprofit organizations as a change agent to improve overall organizational impact. Additionally, she works with pharmaceutical and biotech companies offering program design to improve national-level patient engagement activities. Here she is able to facilitate the work of community, clinical, and research worlds, merging them together to build bridges. Her current work includes partnerships with the Pacific Sickle Cell Regional Collaborative, the Sickle Cell Disease Foundation of California, and Pfizer's Council for Change. Previously, she implemented and managed HRSA's National Newborn Screening Project, in addition to others with funding from FEMA, DHS, and CDC. Her areas of expertise include strategic implementation, inclusive of executive coaching, program design, patient engagement, and statewide advocacy. Jennifer is a graduate of East Carolina University's Master of Public Health program, and she currently serves as a member of the MeFine Board of Directors. So I'll now turn the presentation over to Mary and Jennifer, and I'll be advancing slides for you guys.
All right,
Welcome.
you. Thank you. So first, this is Jennifer. First of all, thank you, Faith and Susan and the folks who put this together and for inviting us to speak. I think it's so important for us to share and learn from one another. These kinds of webinars, for me, fuel us and offer solutions to problems in creative ways. So again, thank you. So second slide, please. I want to paint a picture today about the general charitable giving landscape in the U.S. That's how I'll start. And then explain to you about data and how it affects all of our abilities to do work and to do it well. So starting with a few general stats. Americans gave a total of $427 billion in 2018 alone. That's quite a bit of money. The largest source of that giving came from individuals at roughly 68%, followed by government and private foundations at 18%, bequests at 9%, and then corporations gave a total of about 5% of that, 427. And according to the most recent data that I could find, there are more than 1.5 million charitable organizations in our country right now. Now, to describe how these dollars were used and all the kinds of work that was funded with these dollars, the donor dollars were placed into 5 categorical buckets. The majority of the charitable dollars went to religion at 29%, education at 14%, and then human services and grant-making foundations each at 12%, and then health at 9%. Not given any other disqualifiers, we as sickle cell disease nonprofits are only eligible for about 21% of total giving under those 2 buckets, the bucket of health and the bucket of human services. Next slide, please. Now, if we narrow that down even further and take a look at the demographics of our organizations, that means the people who lead them, not even the people that we serve, just our leaders, we will see that our opportunity for funding and sustainability becomes even harder to attain. The chances become much slimmer for us getting the dollars that we need to serve our communities. Most of the studies show that most nonprofits leading organizations that address minority-facing issues are actually led by minorities themselves. And in sickle cell disease, we know most of our colleagues, and in the CBOs, that is. And most of them, I would say roughly, in my opinion, 97% are Black-led. And this statistic, or this slide, shows that the chances of our funding, excuse me, this slide shows that the chances for our funding just slimmed down once again to less than 3%, because total, only 12% of that total funding that we talked about earlier goes towards minority-led organizations. That, unfortunately, this was from 2005, but these trends are consistent until now. Next slide, please. So let's continue painting our landscape here. According to AHRQ and then the NHQR, roughly 33% of the U.S. population identifies as a member of a minority group. This was as of the last census. You can see that our estimates of each ethnic group are broken down here. And then by 2050, we're estimating an expected shift from the 33% to 50%. The sad thing about this is that our country continues to fail its citizens, in that racial minorities are far more likely than non-white counterparts to be poor, to be near poor, or live without a high school education. Next slide. We know that all these factors contribute to much poorer quality of life and healthcare for the same people, these very same people. Remember that number, 33%. Next slide. All of this data highlights a very important factor. And common sense tells us that the scales remain imbalanced, and it will never be balanced as long as people, because of their skin color or economic backgrounds, are continuously denied the necessary and equitable amounts of resources to deliver the right kinds of resources and services for our people. We know this is true because if we go back to our numbers, the 32%, which is the percent of minority population in the U.S., who only receives 12% of the funding dollars to support any real growth, improvement of areas where it were needed. Next slide, excuse me. This cycle of huge disparity continues over and over again. We know this. But one way, not the only way, that we at the foundation have been able to break through some of the enormous barriers that have been placed in front of us in some very recent years with SCDF is through strong partnerships and the use of some very, very strong data. For most corporations and nonprofits especially, data capital is our single biggest asset. So Susan Polikonis and PHI, they have been key in helping us meet some tremendous needs and prove some big data points within the state of California. Data does several things for us. It sells our products. Our product happens to be a service as a CBO. And our services that we provide are for those who need it the most. Our data draws attention to our work and it shows the impact. And then over time, hopefully we can show that how our work has eased the burden of the communities around us that we serve as a whole. And largely, excuse me, data also supports needs assessments, which show proof of the need to continue our work. Data legitimizes our organization, and it also allows us to continue to serve. So hopefully in this brief amount of time, the story I just created for you with the statistics outlined here, we could have done much more digging. I just wanted to paint a picture of how challenging it is and will continue to be for us and our community to get resources we need to do our great work. The SCD community providers often suffer kind of our own sort of economic determinants of health that create barriers to doing our best work. But with that being said, I hope that it motivates all of us to continue to find tools like the use of data to begin leveling the playing field. Data and how we use it will drive our missions, our goals, our successes, and even when the deck is stacked against us, it's still something we can use to prove our case and to make a real impact. So I turn this over now to Mary to explain to you how we use our data.
Thank you, Jennifer. And working with Jennifer is always an educational opportunity for me. She brings new information to our process all the time. But let me say from the very beginning now that data has been our friend. And working with the SCDC program has been very beneficial to the foundation, as we are able to use data to support the narrative in our proposals, inform legislation and policy. We're also able to create and make sure that there are others that know the real story behind these numbers. So data has been our friend. Next slide. And you can do the next slide. So California is a huge state. And we lived in Los Angeles for about 58 years. But more recently, in the last 5 years, our organization moved down into the San Bernardino, Riverside County area. We still have a strong presence in Los Angeles because of the MLK Adult Clinic. And additionally, Charles University, which is located across the street from the clinic, is now going to provide us with an office space so that we will have someone in that office 4 days a week. The current legislation that we just had educated and informed our elected officials as to where people with sickle cell disease live and where the need is for care. And this map will definitely show you where the numbers are. And this map was created through the SCDF. Next slide, please. Partnerships have been a critical element in the growth of the foundation. We have a partnership with the SCDC. From time to time, we have provided data for them and the work that they're doing. In turn, we are able to benefit from the data that they collect and use that data to support the funding request. Next slide. Faith mentioned a little while ago in her presentation that there was legislation that was recently passed. And so I want to give you a little bit of background about that. The SCDF was the key player in how the recent legislation and funding appropriation was approved by Governor Newsom. Just so that you are aware, this entire process started as a result of the Foundation's 60 years of service celebration. Our work, the patient family testimonies, our partners sparked the interest of a lobbyist that attended our dinner. And following the event, he called me to ask how he could help. After I realized that he was offering his services for free, my mind spun out of control. I contacted Jennifer. We started sharing some ideas because initially the thought was, this is for the Sickle Cell Disease Foundation. But as we both started writing out a plan and looking at what needed to be in California, we realized that the magnitude of the problem was much bigger than just funding for the foundation. And therefore, we talked with our partner, Dr. Diane Nugent at CIBD, and asked her to join us to figure out how we could create a plan that would benefit the greater good for adults with sickle cell disease in California. And we created a proposal that identified the problem, presented a solution, and we asked for funding. Without a doubt, SCDC data was used to inform and educate our elected officials about the dismal issues facing adults in California. Data moved this needle very quickly. Next slide. Again, we are using SCDC data to educate primary care providers, to offer our programs and services, to offer opportunities to refer patients, and to help to educate these providers that are caring for some people with sickle cell disease, but that do not have as much education as they should, for the full care of a person with sickle cell disease. Next slide, please. So using data to build SCDF capacity has been intriguing, and it's been fun, and it's been challenging. But building capacity is a critical component with any partnership. And the foundation has been an equal partner in all endeavors. We are at the table. Decisions are not made without us. We find ourselves as an organization that runs on the word of integrity. We say what we're going to do and we do it. And we operate from a single focus, always. One is this: are we doing our best for people with sickle cell disease? It's not about me. It's not about how long I've been here. It's not about any of that. It's, are we doing the work that we are charged to do for people with sickle cell disease? Next slide, please. So as we move forward, we are now collecting data on all of our programs. And this is important because it helps us to report the impact of our funded programs, and it helps us to demonstrate that we can deliver. We put our money where our mouth is, and that, I think, is very important in this process. I have always operated from the point that we have to do more to prove that we can, and data has helped us to do that. Next slide, please. Finally, we have to understand and make data work for our organization, and we have to make data work with your organizations. I'm suggesting that if you're a community-based organization on this webinar, go through your files and spreadsheets and invest in some software that really helps you track your data. It's going to take a lot of time, but you need to go deep and you need to get it done. At the end of the day, you will have a system that helps to tell your story and backs up what you say you have and what you can do. Sometimes we create our own barriers to our own success. Don't shortchange your organization. Create a path for you to create pathways to success. Trust us. Data works. Thank you.
Hey, thank you guys. That was great. Mary, do you want to just give one example of the type of data that you collect and an example of what you use it for?
Well, let's see.
Or you can think on that, and then we could talk about it during the Q&A.
Okay, that's a good idea.
Okay. Thank you so much. That's great. Again, we will take written questions at the end of the next presentation. So I will now introduce the second set of presenters. They're from Nevada. We have Dr. Nick Abdul Rashid, who is a practicing pediatric hematologist-oncologist in Las Vegas, Nevada. She graduated from the University of Nottingham School of Medicine in the United Kingdom in 1995 and has been in practice for 21 years. She completed pediatric residency at Lincoln Medical Center in New York City and a pediatric hematology-oncology fellowship at Montefiore Children's Hospital in New York. She is the director of the Sickle Cell program at Cure for the Kids Foundation in Las Vegas, Nevada, and she's the principal investigator for the Pacific Sickle Cell Regional Collaborative in Nevada. She is joined by Ms. Linetta Barnes, who is the mother of a 13-year-old Sickle Cell Warrior. She is an adult critical care registered nurse and the president and founder of Sickled Not Broken Foundation of Nevada. The foundation's vision is to enhance the quality and quantity of life for those affected by sickle cell by encouraging the unification via awareness, support, and education of sickle cell warriors and healthcare champions. She hopes to decrease stigmas and misunderstandings related to sickle cell disease. The foundation has a collaborative relationship with multiple organizations, including Nevada Childhood Cancer Foundation, Cure for the Kids Foundation, Pacific Sickle Cell Regional Collaborative, and Dream Sickle Kids Foundation, and others. It strives to continue networking to enhance the sickle cell culture and capacity locally, statewide, and nationally. Ms. Barnes is currently enrolled in a master's program for nursing education and public health at Grand Canyon University to support her vision. And with that, I will turn the presentation over to Dr. Rashid and Linetta Barnes. Welcome. And I need a second to get your slides up.
Thank you for that introduction. Can you guys hear me?
Yes.
Okay, hi. All right, hi, I'm Dr. Rashid, the Director of Sickle Cell Disease Program at Cure for the Kids Foundation. So we've been invited to describe our experience in Nevada, where we collaborate between the medical professionals, I guess, with our community-based organization in building a program for sickle cell disease. Next slide. So a brief introduction on sickle cell disease in Nevada. Unfortunately, we were not part of the CDC surveillance. So we have a guesstimate of how many patients we have here in the state, and we think we have roughly 500 to 600, between 500 to 600 individuals living with sickle cell disease. Majority resides in Southern Nevada, that is in Las Vegas. The state offers care for most children living with this disease. Cure for the Kids Foundation is the only pediatric hematology-oncology center, and we have a sickle cell disease treatment center that treats all children and some young adults. Unfortunately, there is still a major gap in quality of care in the state, and an increase in, as we know, morbidity and mortality as youth transition into adult care. Most adults are still getting most of their emergency care in the emergency care centers instead of going to a primary care provider. Next slide. We don't know what the prevalence of people living with sickle cell trait is in the state. A lot of Nevadans are still unaware of their status as a carrier and are diagnosed when their child is diagnosed during a newborn screen. Although there is no serious health effect related to sickle cell trait, or it's rare, I feel it's important for people living as a carrier to be educated about such impacts. And also there is a lack of awareness about sickle cell disease in general within the community, where there's still, which leads to a lot of misunderstanding and unfair treatment to people living with this condition. Next slide. So the challenge was to build a sickle cell program or to improve the care of individuals living with sickle cell disease. Prior to 2014, there was no comprehensive sickle cell center, even for children, or a medical home for our patients. Most acute care was provided in the emergency department and hospitals. And then blood transfusions was provided in multiple hospitals. We didn't have any community outreach programs. There was no community-based organization. There was no initiative to educate other providers in the community. And then there was a small sickle cell support group that was not very active, but was not really providing patient education, and there was no patient advocacy groups. And there was no transition program for our teenagers going to adulthood. So what happened in 2014 was that prior to that, there were two, I guess, small pediatric hematology-oncology clinic, and then we merged into one. I joined Cure for the Kids Foundation. And then we also became part of the Pacific Sickle Cell Regional Collaborative, which was, I feel, a huge game changer because it made us feel part of a big community, and we saw what other states were doing, and we felt this we had to do here. Next slide, please. So what we set out to do was to establish a sickle cell treatment center. So before we tried, we can try and change what's happening in the state, we felt we needed to change ourselves first and provide good care for our patients, and then use that as a guide or challenge for other centers to do the same. So I set up a comprehensive sickle cell disease clinic. Every other week, we try to meet with patients. Sickle cell patients are scheduled to meet with me alongside with a neuropsychologist, a social worker, a child life specialist that work with the child about their condition. We have a palliative care pain specialist that go over a pain plan for our patients so that they have a guide at home, and also to take with them to the ER if they had to, so that the doctors in the ER has some sort of a guide to start off with to start pain medication. We also have Sickled Not Broken Foundation, Linetta Barnes, come in and meet with the family to educate them about what's happening in the community and try and get them to be involved, and also help us with our transition program, which she's going to explain more about. We set up to improve access to acute care for our patients. So the NHLBI guideline says that for pain, patients should be treated as an emergency and come in and receive treatment within 60 minutes of arrival. And so we set out to do that, and that has significantly improved in our patient. We have order sets that our providers just kind of fill up, and the nurses are aware that they need to be seen right away. Same goes with fever management. I developed an outpatient transfusion program where we have 2 hospitals that I've streamlined so that they can get their transfusions for those who are on chronic transfusions routinely without any hiccups, any problems. And then now, of course, we've switched that to majority of our patients on chronic transfusion getting apheresis or exchange transfusions, which we've arranged at one hospital to make it more streamlined. We're also active in research and clinical trials through the PSCRC. We were involved with the minimum data set. We have some clinical trials with pharmaceutical companies, and then we are doing ongoing QI projects as well. I'm also active in educating families, patients about hydroxyurea, and we continue to improve our prescription education and increase prescription to our patient population. I'm also part of the advisory committee for the newborn screening committee here in Nevada. So I get a list of patients that have been diagnosed with sickle cell disease and other hemoglobinopathies, and also the babies diagnosed with sickle cell trait. And so we then attempt to contact the pediatrician or the patients directly to bring them in so that we can, for those who have sickle cell disease, to start treatment and follow-ups. And those with sickle cell trait, we attempt to counsel them and also counsel the families. We offer the patients, the parents, testing for sickle cell trait. Right now, if they have insurance, then we will try to do that in our clinic. Linetta is going to touch a little bit about the sickle cell bill that will allow us to actually test parents if they wish to when we see the baby under the baby's insurance. So if the parents do not have insurance, they can still be tested if they wish to. We've also increased our community outreach and education. We do family education evenings every quarterly and encourage patients and families to attend and speak about whatever they wish to learn about. So we usually at the end of each session get a sense of what else they would like to learn about and try to teach, to present that. And then other provider outreach education as well, grand rounds, invited speakers, CME. And recently we just completed a sickle cell symposium in partnership with Sickled Not Broken Foundation. And Sickled Not Broken Foundation is very active in helping me with the transition program for our teenagers in educating them to become, educated in their own condition and to be good advocates for themselves. So it looks like a lot that's been done, but all this was done with the help of our community-based organization. Of course, I could build a program, but it won't be any good if the patients are not aware of it and if the patients don't have a buy-in for it. Next slide, please. Next couple of slides, I just wanted to show the incidence of patient babies with hemoglobinopathies in the state since in the last, well, between July 2014 and July 2018. As you can see, the dark green is the hemoglobinopathies, and that's the largest section of the pie, and that was 61 patients diagnosed. Next slide. And in this table, it just shows the breakdown of the hemoglobinopathy. So of all that, sickle cell SS, there were 26 babies, and SC, there were 14 babies born in that 4 years. But on the top right-hand corner are those diagnosed with some sort of trait. And these are the ones that some of the parents were not even aware that one of them carried it. Next slide. So now that we've built somewhat of a program in our own clinic, we're hoping to be able to now work beyond and build some sort of a program for the rest of the community, especially any adult patients that are living with this condition. We've created somewhat of a Nevada State Sickle Cell Action Plan. And I'm going to hand this over to Linetta to present how we collaborate to achieve some of these action plans that we've come up with. Thank you.
Thank you, Dr. Rashid, for introducing. I guess it's a lot that we've done so far. It sounds like a lot, like you said, but advance the slide, please. Next slide, please. Uh-oh.
Hello? Sorry, technical difficulties. Is this good?
No worries. Yeah, yes, I can hear.
Is this where you want to be?
Yes, that's fine. Yes. Thank you so much. So, yes, back one, forward one. Yes.
One more?
Right there. No, that's perfect right there. You're good. Thank you so much. So, a lot of information on, no worries, on my end, so I'll move quickly. So currently in Nevada, there are 3 active community-based organizations that are solely committed to, decreasing sickle cell disease-related healthcare disparities. But out of those 3 foundations, we all have kind of identified a primary age range. So there's Dream Sickle Kids Foundation, and her primary focus is the birth to 12 years of age. And this foundation is amazing, and it's led by the leadership of Georgine Glass. Second is the foundation that I'm affiliated with, Sickle Not Broken Foundation. As they said previously, I'm the founder and president of the foundation, and our primary focus is the ages of 12 to 23, which are the children that are transitioning. Lastly, last but not least, is the Adult Sickle Cell Foundation of Nevada. It is under the leadership of Pamela White, and their primary focus is 21 of age and older. So those are the main community-based organizations right now based out of Las Vegas in the state of Nevada. Advance the slide, please. So Dr. Rashid and I, like she said, we're still on high from the recent symposium that we were able to take part in. And I know our goal and our focus is to try to explain how working together, how the community-based organization working together with the medical facility makes it better for the sickle cell community. We definitely had great speakers, and when everyone left, they were speaking about how they were grateful for the education. It was long overdue, and that wouldn't have taken place without that collaboration. So also Dr. Rashid mentioned that we are actively collaborating to complete the Nevada State Action Plan between her organization and also all the community-based organizations. I like to say that the action plan is really almost like the gorilla glue, if you will, that's kind of holding us together. It kind of helps guide us and gives us direction. So definitely I would encourage all states, if they haven't started, to work on a action plan. I'm not sure the age group on the phone, but I don't know how many of you guys remember the Transformers or the Power Rangers, if you will, how individually they were very mighty. They knew all the karate moves, right? But when the enemy tried to overtake them, when they were faced with that barrier, they would link up, join forces, and they would become stronger and more powerful than any barrier put in front of them. That's what the collaboration between community-based organizations and the healthcare community does. It gives you that strength. Collaboration equals strength. Collaboration also equals access. Oftentimes, the community-based organizations know that the people are out there, but they have no way to contact them. So guess what? By collaborating with Dr. Rashid's organization, we've been able to come to the comprehensive clinic and make phone calls to find these individuals, to invite them to the community activities. Same with them. Sometimes they have new treatments, new information to disseminate, and now they can go through the community-based organization to disseminate that information. So collaboration. In addition, collaboration equals resources, it equals trust. Sometimes the community would trust the community-based organizations a little bit more than a healthcare providers. And by working together, we're able to help develop care plans that will benefit the child and also the adult to have great outcomes. And last but not least, collaboration equals less burnout. There is a lot that needs to be done in the communities for sickle cell anemia. And by working together, it doesn't make any one organization, any one side burned out from putting in a lot of love to the community, and therefore it equals more production. So for those that are on the line, you do not have to collaborate if you're a CBO with your primary care providers, with your hematologist, but I encourage you to do so to make a greater impact within your community and to encourage positive change. And I'm going to quickly go over some of the successes, if you will, that we've had by collaborating. Through the Nevada State Action Plan that's being developed, one of the goals is to increase education and awareness. And so the goal is to get out more sickle cell trait education and sickle cell disease education and educate the health professionals. And one of the CBOs, Dream Sickle, has done amazing with this. She is phenomenal. She's very, very active in social media with events. Her motto is make sickle cell popular, and she has done so through her collaborations. And so that is one of the things that's really benefited our community as far as our education and awareness. And of course, we just had the Sickle Cell Symposium. So again, collaboration is important. Please advance the slide. And so here are just a few pictures of some of the events that's taking place in the community. You see Dr. Rashid up in the corner. She was at one of our local hospitals educating on sickle cell anemia and blood transfusions, and that was a great turnout as well. Next slide, please. So this is dear and near to my heart, and this is the transitioning piece. Part of the state action plan is to assure timely and complete transition to adult care. It is very much known that any child that's transitioning from, say, middle school to high school to college out into the adult community, it's a difficult transition in general. But when you add sickle cell anemia onto that, that just puts a whole nother barrier or challenge, if you will, for these young men and women. And so through our collaboration, Sickle Not Broken has been invited to be a part of the Sickle Cell Comprehensive Clinic. It's given us a way to come in contact with the youth starting at age 12 and introducing them to the ideal of transitioning and also to their parents. You know, it's a process for both because they both, one has to step up and one has to let go. So we're able to provide that education within the sickle cell comp clinic. And I know Dr. Nick Rashid and their team, they started transitioning on their appointments, but they only have so much time. So guess what? Collaborating with your hematologist and your providers allows you to get in the community and meet with the people for more time in the community. So we have started a transition program based off the program that's in California, SC Crew. We are so grateful to Mary Brown and her team for sharing a lot of their ins and outs so we can duplicate that here in Las Vegas. So as of this year, we started a 4-month pilot for the transition program. And next month, October, we will start the program back up. So we'll go from October to June of next year. And the focus of that is with transitioning, you wanted to enhance these young individuals to have awareness and education about sickle cell. You wanted to encourage them to support themselves and to support one another, and also to receive support from the community. But very important, you want to encourage them while they're transitioning to be empowered through advocacy, legislative authority, and confidence, to become independent for self-care management, and to have integrity for their morals. So that is a little bit about our transitioning program that is here. And this year, we were so grateful that we were able to sponsor 2 of our young males to attend the sickle cell camp in California. They had an amazing time. Advance the slide, please. And there's a few pictures coming up where you will see the young men making crazy faces over there in the corner. You see some of the groups that we've had with the youth for the transitioning. We do a lot of outreach programs we're invited to. And in the middle there, you will see a young adult sickle cell warrior who is pouring back encouragement to a younger sickle cell warrior. So we try to have them encourage each other. Next slide, please. So another way that our collaboration has worked is through advocacy and training. This has been amazing. It has been, there's nothing like this that has been done in Nevada. Recently, AB 254 sickle cell bill was passed here in Las Vegas, Nevada, or I just should say Nevada. And what it's allowing us to do is prioritize sickle cell disease in the state of Nevada. So if you're in a state and there has not been a bill passed yet, I encourage you as a CBO and as a medical provider to start working on one. It definitely makes a difference. It definitely requires the providers, the acute care setting, to acknowledge sickle cell anemia and I want to say force, but have some motivation to make change within their organizations to benefit the population, especially the adults. Really quickly, I'm going to go over a couple of the items that was on the bill. Next slide, please. So on AB 254, back one slide, please. Yes, perfect, thank you. One of the things that took place is that we do not here in Nevada, and I'm hearing this across the board when I go to different meetings, we don't know our numbers. We do not know exactly how many have sickle cell disease, how many have the trait. And like Mary Brown and Jennifer mentioned, the data helps us. We need the data. So this bill that was passed will allow us to set up the system to get the numbers and get the data so that we can get the funding, hopefully, and get the support within the community to be able to have a standalone sickle cell clinic for infusions or a dedicated floor on a hospital for sickle cell, especially for our adults. They are hurting and we need to get something for them. It also, I think Dr. Rashid mentioned for the newborn screening, it allows the parents to be tested right then and there. A really huge part of the bill was that, some of our sickle cell warriors are on supplements. And so now the medical community, Dr. Rashid was very, very much pushed ahead to say, we need those supplements to be covered. We need them to be able to get their controlled substances a little bit longer than the average person because they have a documented need. And so this bill that was passed is now going to allow supplements to be covered according to a committee, as well as a longer list for the controlled substances. It also had in the bill talking about transition programming and for the insurance companies to support that and other adult services. So the bill is amazing. We're very excited. We thank Assemblywoman Dina Neal for her tenacity of moving that bill forward. Next slide, please. And here you'll see a couple of pictures of us at the bill signing. At the bottom there, you see the whole team there. So we were very, very grateful. It was a great day. Next slide, please. So last but not least, the last topic to address is address gaps in care. This is a huge one. This is really focusing on our adults. You know, Pamela White takes care of the Adult Sickle Cell Foundation, and this is where her mission really is, trying to access specialty care. You know, not just hematologists, not just primary care, but also lung specialists, you know, pulmonologists, heart specialists, to also be educated about sickle cell anemia to provide what the population needs. To improve patient experience, and it's really, really huge. We're looking to start our next project, which is to create a pain management protocol set using the NHLBI and other guidelines. Right now, you go into any of the hospitals and you get different care depending on where you go. And many providers have expressed not knowing what to do when they get someone with sickle cell anemia, and they just do their best. But sometimes your best is not enough. And they recognize that, and they want to be a part of the change. So we're just trying to identify those champions. And through the collaboration with Dr. Nick Rashid and the CBOs, I'm confident that we'll be able to start that process. Last but not least, before we leave this page, is that through the collaboration, we get a lot of people here traveling to Las Vegas. And what happens is they have no primary care, no one to help advocate for them in the hospital. Dr. Rashid, oftentimes we are able to call her and just get her opinion, her recommendation on a couple of things. And although it's not official, if the providers would like to call her, they have that option. They can have a little communication and maybe come up with a better care plan. So having this collaboration really does help the families. Next slide, please. And so what we like to definitely let everyone know through collaborating, you know, everyone has an experience, whether you're a provider or whether you're part of a community-based organization, you're a parent, a family, a friend, or a patient. You can have a possibly negative experience, but we want to focus on the change. And a quote is, the secret of change is to focus all your energy not on fighting the old, not on the poor experiences, not on the heartache, not on the pain, but on building the new. And the new is Sickle Cell Unite. The new is bridging the gap, and that's what we want to promote. Next slide, please. And in conclusion, you know, community-based organizations, again, are critical to bridging the gap between the community and the medical professionals, and, you know, and improving a sickle cell disease, which is a chronic disease from birth until, you know, the whole lifespan. So with that being said, that concludes. Next slide, please. And if there's any questions, thank you.
Thanks so much, you guys. I'm kind of blown away by how much work is being done in the Western region. It's really incredible. We have this line until 3, and I am going to start going through the questions. But if people have more questions, we've already received some. If people have more questions, please write them into the question box, and I will read them to our presenters. I have a comment, I guess, from New York State, that New York State is not doing their best to help patients and families with sickle cell disease. There have been 2 bills in the legislature for the past 6 years, trying to get funded from the governor. And the question is, how did you, California, acquire the funds to start 5 new sickle cell treatment programs? And in New York, they're only asking for $5 million for hospitals across New York State. So, but I guess I would kind of widen the question and ask both sets of presenters, how did you get legislation passed?
Well, I'll start. This is Mary Brown. Well, it wasn't easy, but I think as I said earlier, and it's really known. I think there were two major factors that helped us get legislation passed. And one was that we had data that could support our ask. And I know for a fact almost that I'm pretty confident to say that if we didn't have the data, we would not have gotten where we are in the state of California. And I think the second most important factor was that we had a lobbyist that was committed and understood the plight of adults with sickle cell disease. And he did as much work or more work than we did. It was about a 1.5 year process, and it was constant. It was change this, do that, rewrite this, push this here, let's go meet there. We didn't start with all of our high-level elected officials. We started with their staff. And I think that that's another lesson learned in this process. Start with the staff and start to educate the staff, because the staff have the ear of their elected official. So I think that there are a combination of things, but the data really helped move the needle for us here in California. And the story, it told the story. So when California looked at that data, they were basically embarrassed by what California had not done for people with sickle cell disease. And then finally, what I would come up with was with what Senator Holly Mitchell told us. She said, you identified the problem, you've come with a solution, and you've made a reasonable ask. That's the mantra that I think that all legislation should really start with. What is it? How can you fix it? And is it reasonable to be asking for funding?
Thanks. And I wonder if Nevada wants to weigh in. I think one thing that I wanted to bring up before I let you speak is in none of these cases is the amount of money that's being asked for very large, since this is a rare disease. So in California, I believe it was $15 million. And in Nevada, I know that Dr. Rashid had said the amount was negligible for the legislature. And then New York State is only asking for $5 million. So it does seem like the focus is not so much on the money in the states that have been successful. It's been on the need. But I wonder if the folks from Nevada want to comment on their legislation and how they got it passed.
This is Linetta. What I would probably say for us in Nevada is there was nothing. I don't know if there's anything in New York, but there was no support at that time for sickle cell disease. And so we had nothing to compare. The legislative, I don't believe, had too much to compare to. But I know a big factor was two things I can say. One was, really, again, the collaboration, getting in contact with the families. I know right before we had a hearing, Dr. Rashid's office had a educational night, and we encouraged them to attend the hearings and to testify. And I was told that the stories, when you are in front of them testifying, you have to have those stories, because they don't understand the burden, if you will, or the challenges, if you will, of being a caregiver or a patient with sickle cell disease, unless you give them those stories that really tug at them so they understand, to say, you know what, they're worth it, if you will. Also, I would say that, and this was Georgine Glass, she was very, very, very on top of making sure holding our champion accountable, following up, making sure she was seeing where the process was. So that's the recommendation, to make sure that, once you get a champion on board that's for you, for your bill, for your funding, to make sure you're communicating with them regularly and always building support throughout your community while you're waiting for that next, hearing, if you will.
I would agree with Linetta on that, and I am remiss to have missed the fact that we did have a champion, Assembly Member Mike Gibson. He definitely carried the weight and the ball for us. And I think the other part of that too is as you look at community work and clinical work, you have to have a team. And the team that we put together went before all of the legislators all the time. I was present, Dr. Nugent was present, Judith Baker was present, our patient voice was present in Lance Jones. We wanted to get Jennifer out there, but we just couldn't pull her through. But we did have a team of people that were there. And when it was asked about the patient person voice, I didn't say a word. Well, if we had our person there with sickle cell disease, they spoke. I always relinquished my time to them. And I think that those were some other components that really did help. So to Linetta's point about the champion, it's keeping him or her involved and completely focused on your legislation, because there's so much other work for them to be doing as well.
Thanks, you guys. Here's another set of questions from somebody I know who runs a CBO up here in Northern California. She asks, what types of data should we collect? And I know she already does collect some data, but I think she's asking for kind of specifics of, what you collect. She has a question on what type of software to use for the data collection and also what to use it for.
So this is Jennifer. I can wing this one. So we track all of our program activities. So any funding that we get, we try to make sure we have our metrics there, and we always promise and report back, actually over-report back what our funders give us. So if they ask us for 5 key points, we might give them 10 back just to show that we're actually doing the work and we're going above and beyond. But some data points that we track, for example, we track our outreach activities. We had lists of providers from SCDF, Medicaid who target a certain area. So we called those providers, conducted outreach to them, and then we ended up reporting what the result of that outreach was. And from that, for example, we ended up having a 30-minute, session with Dr. Susan Claster, who educated about 65 providers on sickle cell disease care. These were providers from FQHCs and non-FQHCs, and then just general Medicaid providers. And from that, we have contacts of providers who actually want to connect with us to refer their patients. So we collect, again, outreach efforts. We track our promotions. So if we spend time promoting things like on social media, we track to see who's engaged. We track to see what kind of feedback we're getting, how many impressions we make. We also, importantly, though, we have general intake forms. Our general intake forms look like case management forms for any other program. It collects a lot of data points like demographics, income, or, what are some of the barriers that are you worried about your utilities being turned off, or things like that. Those, we expand our general intake form and include medical information, what type of sickle cell disease they have. We have that information that we were happy to share, I'm sure. But to extend that, we actually track the social determinants of health, which we adopted from CMMI, which is Medicaid and Medicare services. And that helps us to know who we're working with and which types of challenges our population will face, so that we can have our community health workers ready to overcome those challenges or help them get over them. So, for example, transportation or food challenges or things like that. And I think another example is our XP Career Program. We use the transition readiness assessment, and we track our programs and track the patients to see how ready they are to move to adult care based on provider assessments and then personal assessments and then mentor assessments. And so every time that person goes to a mock clinic, they're rated, and then we compare those scores with the year before to see how they improved. And if they're over, I think it was 80 or maybe 90%, then we deem them as ready to move forward. If they are not ready to move forward, then we'll go back to those gaps, those areas of those gaps where they might need some extra attention, and re-educate them on those areas for another year, another 6 months, or whatever we see fit, and then they're tested again. So those are some examples of some points of information that we collect. And then the software systems, there's such a huge range. We're using Apricot right now, although there are others out there such as Sumac, but we are looking at, building out our program because we're collecting so much more data, and we want to make sure we're efficient at doing that. So that's a little bit of information about that.
Thank you so much. Another question is, what do you suggest when there aren't any active community-based organizations in the state with which to collaborate? And also, P.S., I love the Power Rangers comment, which I do too. I don't know who wants to take that one. Maybe Dr. Rashid, you could give the clinical perspective. I think I might know the answer, but what would you do? What have you done?
Yeah, well, before we had CBOs, I have to be honest, it was very hard to get, out there into the community. So what to do? Encourage someone to start.
I know.
Right. Start one.
I was going to say, Nick, I know before it was started for me, I know every time I came in with my kiddo to bring them to you, you were like trying to encourage me every time, and I fought it every step of the way, and but every time I was there, you're like, you should do it. And so I think you stopped me out. So.
And aren't you glad you did? See?
I am. I'm grateful.
Yeah. It was hard. I initially started a few years ago, we started with like a small support group. I kind of encouraged families to come, parents to come. So we would do this after clinic, after we finished clinic, about 5:30, 6 o'clock, have everyone who attended. And then I'd give just education to the family so that they learn a bit more about their condition. Problem with us as providers is time to go beyond that, to go to the hospital. But any opportunity I had, I would, if I'm invited by the residents, I'd give a talk there and talk about sickle cell. If the ER says, hey, do you want to come and tell us a little bit more, I would go. But having CBOs just kind of extend that arm and legs for me, making me a bigger transformer, I guess. Go out there.
I would say too, though, for the one that asked the question, is to recommend them attempting to identify one of the parents that they do feel would be a great advocate or a great, leader for a community-based organization, and encouraging them to realize there's other organizations within their area that they can kind of lean on. For us, we're part of the Pacific Sickle Cell Regional Collaborative, and the fact that we're able to lean on California for ideas, like we don't have to recreate all the wheels. We get support, we get ideas, and we don't feel alone. When you feel alone and you feel overwhelmed, you don't want to start a community-based organization. It's just too overwhelming to even think about. But when you realize there is support and help to get you going, then you're more likely to want to do that. So I would say, see what organizations are close by to allow your champion to, lean on to.
Yeah, I think that a lot of new organizations will reach out to established organizations and really like the way that California went to Nevada to share their knowledge. There can be a lot of support. I think I have a final question for Mary Houlihan, if she's still on the line. And I'm not positive either of us will be able to answer this, but it was a question about the data we provided for a grant about the link between sickle cell and cancer. So I don't know, Mary, are you still on the line?
Yep, I'm still here.
Susan is the right person to answer this question, but do you know much about the link between sickle cell and cancer or about the grant proposal?
My understanding is the grant proposal is something that is being led by Head 1, but I could be completely wrong about that, but that's what my memory is. I believe it's for an NIH grant. I'm not sure other than that, I'm not sure what
UC
sort of
data
information I could provide. Yeah.
I just want to thank everybody for participating. Thanks so much to the presenters, and everyone have a great day.